congenital hypothyroidism, which is extremely important from clinical perspective, not only from pediatric endocrinology, but also from a pediatrician perspective. So what is the most common feature of congenital hypothyroidism, Dr. Sandeep? Yes. Mm-hmm. So if you have 100 children who have congenital hypothyroidism, what is the most common feature to all of them? Okay. So at 2 weeks, what will be the most common feature, Nimisha? No feature. So that is the biggest message. So if one message comes out of this is that every newborn needs to be screened, because the best of pediatric endocrinologists can identify 10% at birth. And the time which is crucial is 2 weeks. That's when you want to diagnose. It's very, very unlikely to be identified from that perspective. So we need to have a clear-cut understanding of universal screening, which becomes important. So what we'll do is that we'll talk a bit about pathophysiology, then the various causes. A lot of time will be devoted on how do we screen in normal and preterm individuals, and then we will carry forward in terms of management and Q&A at the end of it. So it's part of our MedEClasses lecture series. And so we have now started on thyroid. We have already had series with regards to the various aspects of growth, electrolyte, calcium, obesity. So a lot of it has been done, including the pubertal disorders. So we are focusing now in terms of the thyroid in that regards. So why is thyroid important? Because we can often have confusion in the beginning. So we had this 20-year-old girl with TSH of 28, which was referred for evaluation. Now, there has been a lot of talk about that in terms of what should be done. But what we need to remember here is that this was too early a time to do a TSH. So this clearly was an unnecessary workup at this point of time. And what we could have done is just to repeat it, and it was found to be normal. On the other hand, we may have the missing of cases also. So this is a 32-week-old neonate on routine screening, had TSH of 7, normal, free T4, was advised, okay, everything is fine, no need to worry about that. But what really happened in this case was that at day 14, we found that the TSH rose. So what we need to understand is that on one hand, we don't want to do unnecessary or too early workup. We also don't want to miss on these scenarios. There is a missing or messing which happens with congenital hypothyroidism, and this is what we're going to cover in that regards. All of you can go and have a look at our website, learning.growsociety.in, which has a lot of resources related to pediatric endocrinology. There are YouTube resources, including this lecture series. I think there are over 100 videos which are there, which you can have a look at it. Our website provides comprehensive tools and courses related to pediatric endocrinology, including a 2-year fellowship program and a pediatric endocrinology for postgraduate program, which is relevant for various postgraduates across the region. We do run a number of brand rounds, journal clubs, and PG lecture series, so you can all enroll. They are all complimentary in that regards. Our publications include the protocols, the basic and the advanced pediatric endocrinology, and our mobile application will help you guide in terms of day-to-day point of care management from that perspective. So today we are focusing on congenital hypothyroidism. When we talk about the hypothalamic pituitary thyroid axis, the hypothalamic TRH is produced, which is basically a tripeptide. It acts on the TRH receptor in the pituitary to produce TSH, which then acts on the thyroid to produce the T4. Now, T4 is a pro-hormone. It needs to be either activated into T3 using monodeiodinase 1, or it can also be inactivated to reverse T3. And we need to remember, when you talk about the fetal physiology, a larger portion of this T4 is inactivated to reverse T3 as compared to T3, while as child matures, there is an increasing production of T3, and this becomes relevant from our clinical perspective. Now, a lot of T3 and T4, over 99%, is actually bound to the thyroxine binding globulin. So only a small proportion of free thyroid hormone is free, which acts on the thyroid receptor, and it has to be actually transported using the MCT8 to the cells where it will act on the thyroid receptor. So when you have somebody who has a problem in the thyroid gland resulting in production issues, that is primary hypothyroidism, the first thing to go up clearly would be TSH, which is number 1, followed by a decline in T4, and T3 is the most useless investigation in that perspective, because there are adaptive mechanisms which prevent the reduction in T3. So if you're talking about screening for primary or congenital hypothyroidism, the most important investigation there will be TSH. So since primary hypothyroidism is the most common cause, most centers across the world are using this TSH based strategy, which is the primary strategy in that perspective. If there is a problem in the hypothalamus or the pituitary, which we call quote unquote a central hypothyroidism, in this scenario, what you're seeing is that you will have a low level of T4 with an inappropriately normal or low level of TSH. So here, if you use the TSH strategy, you will be missing them. But the proportion of central hypothyroidism is significantly lower as compared to the primary hypothyroidism. So the relevance becomes less. Second, most cases of central hypothyroidism, you would have other manifestations because it's usually a multiple pituitary hormone deficiency. So there would be hypoglycemia, midline defects, micropenis, cleft lip, cleft palate, which will point you towards that this could be a central hypothyroidism. That's why most strategies do not use T4 as a backup, because that will lead to more burden and it will also lead to more false positive approach, which I'll talk a bit subsequently on follow-up from that perspective. So congenital primary hypothyroidism is something which can really happen because of various aspects, especially if you have a long-standing primary hypothyroidism, that the fetus has got a very low level of thyroid, there would be a reset HPT axis. So you will need to have much higher level of free T4 to suppress TSH. And this may last for few months. So postnatally, what you may find is that the TSH levels will remain elevated while the free T4 levels are normal. This situation is important to understand because in this situation, you do not need to increase the dose of thyroid hormone just to ensure that the TSH comes down. Remember, your aim is to maintain a normal free T4, particularly in the first 1 year of life. That is more important than maintaining a TSH in the lower range. If you have to maintain TSH low, you may need to give supraphysiological doses, resulting in a high FT4, which is something which is not desirable. Now, how does the thyroid develop? So around 7 weeks of gestation, you've got the thyroid gland. I'll talk a bit about how it develops. Around 8 to 9 weeks, we have the hypothalamic hormones which come into the picture. The pituitary hormone TSH comes around 14 to 15 weeks. So what it tells us is that the fetal thyroid does not produce thyroxine till around 15 weeks of gestation. So it's completely dependent upon the maternal thyroid. So if you have a mother who is hypothyroid, who is inadequately treated with thyroxine, may not be able to transfer enough amount of thyroxine to the baby, resulting in some effects in terms of thyroid abnormalities there. So roughly by 15 weeks, the baby will be able to produce by themselves. Now, the thyroid gland basically has got dual origin. We have been often talking about, when we talk about endocrinology, many glands have dual origins. So you've got the pituitary, which has got a adenohypophysis, which is a glandular structure, and neurohypophysis, which is a neural structure. When you talk about adrenal, you have got the cortex, which again is a glandular structure, and medulla, which again is a neural structure. Pancreas, you have got the exocrine and endocrine region separately. So thyroid also has a follicular and a parafollicular region. So thyroid gland descends from the pharyngeal floor, where it appears around day 24 under the influence of a few transcription factors like PAX8, HHX1, FOXE1, and TTX. These are all involved in the pathogenesis of thyroid development, and their abnormalities may result in thyroid agenesis. From there, this is descending through the foramen cecum to the back, to the lower part of the trunk in the midline region, and wherein around 3 to 6 weeks, the other genes will result in development of the gland. And then from the fourth pharyngeal pouch, we have got the parafollicular cells which will come in. So theoretically, while the follicular and the parafollicular cells are coming from different origin, when you look at the thyroid gland, you may not be able to distinguish it properly. So parafollicular or C cells are going to produce largely in terms of calcitonin, while follicular cells are going to produce thyroxine in that regard. This happens by around 6 to 7 weeks. And that's why I said 7 weeks, the thyroid is roughly developed. But having the thyroid is not enough. You don't have the TSH, which appears by around 15 weeks of life. And then you've got these follicle and the thyroid cells, which are going to concentrate and produce T4. An understanding of hormone synthesis is absolutely important because a significant proportion of infants who have congenital hypothyroidism have a problem in the hormone synthesis. So if you think about it, thyroid gland is largely a iodine concentrator of the body. It basically takes up iodine and then organifies it. So from the circulation, you've got the thyrocyte, and now if you remember the arrangements, inside there is a cavity. So there is a cells, top of that there will be blood vessel, and inside will be the cavity. So this iodine basically is transported by the sodium iodine symporter, which transports one mole of iodine, one ion of iodine to two ions of sodium. This iodine concentrator is hugely effective. It concentrates the iodine by around 20 to 40 folds. But if you have this iodine in the thyrocyte, it will leak back. So what you need to do immediately is to shift it towards the colloid. And therein comes the role of two important transporters, the pendrin, which we all know about the pathogenesis in terms of the Pendred syndrome, and enoctamine, which will push it into the colloid. But till now, this iodine has not been organified. If you talk about how things are transported, remember proton. Proton is actively secreted in the collecting duct. But if it does not get combined with ammonia and forms ammonium, it will go back. So this iodine till now is not frozen. It needs to be bound. So it has to be organified by the enzyme thyroxine peroxidase. And you all know about TPO, along with duox2, which basically is a source of hydrogen peroxide. So you're getting hydrogen peroxide and peroxidase, which is then organifying iodine, and it is going to bind with tyrosine to produce diiodotyrosine and monoiodotyrosine. These of them will then combine to form T4 and T3. Large proportion of hormone which is synthesized by the thyroid gland is T4, but you also have some amount of T3 which is to be produced. And this brings us to an important point that if you have somebody who doesn't have any thyroid gland, you would like to maintain the thyroid hormone at a higher level compared to a normal individual because this T3 production is not happening. So your entire T3 is going to come from conversion of T4. That is why in somebody who has got a primary congenital hypothyroidism, you want to maintain T4 level in the high end of normal, which will be, if you say your levels are around 10 to 20, you want to maintain it between 16 and 20 picomoles per liter rather than the lower end of normal. And this is an important factor to remember. Now, from the colloid, this entire composition of this form will come back to the cells. And herein you have got the DIT, MIT, T4 and T3. And then the TSH will start acting. And TSH has got effect at every step of the process. TSH increases the sodium iodine symporter, it increases the cell size, it increases the cell vascularity, including the TPO activity. So if you have somebody who has got deficiency in TSH receptor, what will happen to the thyroid size? Will increase. So the thyroid increases because of TSH. If the TSH is not acting, your TSH will become small. Similarly, if you have got sodium iodine symporter defect, there will be no activity, so it will be small. So these two conditions are known as apparent athyrosis. So apparent athyrosis means you have got gland on the ultrasound, but you have got no gland on the thyroid scan. That's largely because of either you don't have any sodium iodine symporter, so iodine is not going in, TSH is not there, or TSH is not acting, or something is blocking the TSH receptor, and that something could be the maternal TSH receptor blocking antibody coming from the placenta from the mother. These will have a small size thyroid. All other conditions I'll talk about in terms of dysharmonogenesis, whether you talked about a TPO problem, a DOX2 problem, a thyroglobulin problem, all those problems will have a larger thyroid gland in that perspective. And from here, these thyroid hormones are then secreted, the T4 and T3 go down, and the diiodotyrosine tyrosinase and monoiodine tyrosine will basically then release iodine, which is again going to be used from that perspective. So this is the basic phenomena which you need to remember. The T4 and T3 are basically secreted, and this transport also requires MCT8, which is a transporter. Every mole of T4, T3 produced also involves a release of thyroglobulin. So thyroglobulin levels are a marker of how much thyroid hormone has been released. So they would be a good test when we talk about congenital hypothyroidism and further evaluation from that regards. Now, if you give a lot of iodine, you expect the thyroid synthesis to be blocked. Because if you have too much iodine, what will happen is that the body don't want to continue increase thyroid, it will stop it. But the fetus basically has got exquisite sensitivity to iodine. So iodine exposure to the neonatal period may result in hypothyroidism, which may be persistent. This is not the same as the older children or adults. So iodine has a differential effect as far as the growth status is concerned from that regard. So this becomes important. Now, a word about the maternal fetal thyroid axis. We know that the iodine can freely cross the placenta, as could TRH. The T4 and T3 do have some passage, but TSH does not pass at all. Why is it important that TSH does not cross the placenta, Dr. Sandeep? Is it good or is it bad?
Because the maternal thyroid profile will hamper the baby's.
So suppose you have mother with primary hypothyroidism and TSH was crossing, then the baby will become thyrotoxic. So you don't want that to do. So TSH and insulin, both of them are not allowed to cross the placenta. But T4 and T3 will cross to around 40%. The monodeiodinase activity will inactivate, but 40% will pass. And I'll talk about the overall fetal adaptation, and there you will find that is 30 to 40% may be good enough. So maintaining the mothers in a euthyroid state is good in terms of fetal thyroid function. The other important thing to remember is that these thyroid will take care of the baby's brain development till around 2 weeks postnatally. So if you can identify the neonate in the first 2 weeks and start treatment, you do not expect an adverse effect as far as the brain development is concerned. The TSH receptor antibody can also cross the placenta and, as I discussed, can cause what is known as a transient hypothyroidism. From that scenario, the half-life is typically 2 to 3 weeks. So this may last for around 3 months roughly, but may really last for up to 6 months. The antithyroid drugs can also cross the placenta, and therefore they have a risk of causing transient hypothyroidism in mothers who have Graves' disease and who are on a methimazole, and that can be something to remember. So these things become important. Now, what about the overall adaptation? Now, when we talk about fetus main aim is to grow. All the temperature, all the metabolites, the calorie requirement, the sodium, potassium is being controlled by the mother. So the only role of fetus is to grow. So therefore, if you have too much of thyroid, you don't need to generate temperature. Why do you want to burn calories? So fetus is going towards a mode wherein you have got much more amount of inactivated form of T3 or sulfated form of T3 rather than the active form. So this is an anabolic state. To preserve the brain, you have got a special deiodinase type 2, which is going to preserve from the brain. This is the normal scenario in that regards. So fetus is producing more reverse T3, fetus is producing less T3, and whatever T3 there is converting into T3 sulfate. Similarly, the brain activity is more to preserve the brain function. So this 30 to 40% which mother is giving is good enough. So you may have a fetus with zero thyroid, no thyroid, there will be no problem. Fetus will be fine. Fetus may have no thyroid, no adrenal, no or the pituitary, they will have no problem. They will be born and only the problem will happen after birth. So this is something to understand. So if we talk about gestation, as gestation progresses, the fetus is getting ready for a very, very big event, which is going to happen just at birth. So what's happening is that you're moving from a high monodeiodinase 3, which is an inactivating enzyme, to a high DIO1, monodeiodinase 1, which is an activating enzyme. So what's basically happening is that your T4 levels and your T3 levels are rising. The rise of T3 is later and slower compared to T4. TSH, of course, precedes all of them. And then there's a watershed event at birth, and then the levels come down. So this whole process and this transition is absolutely important from a physiological perspective. As expected, Our T3 is highest around the prematurity, around this 24 to 30 weeks. What it means is that preterm babies may have what looks like a central hypothyroidism. Low level of T4, low level of T3, and a normal level of TSH, which is not very high. So this is something which is very, very common, known as transient hypothyroxanemia of prematurity. What it also means is that you do not need to unnecessarily treat them, and this may cause more problems than benefit. So this is a sort of a adaptation, and they didn't have time to mature. They have born early, and that's why this happens from that regards. Now, immediately after birth, the biggest problem that the baby faces is temperature. The body temperature was around 38 degrees and suddenly the room temperature is around 20 degrees. So you have to do more to increase the temperature, and therefore comes the role of thyroid, which is the non-shivering thermogenesis. So basically, you want to have a catabolic state. So now the switch will happen from a DIO3 predominance to a DIO1 predominance. T4 is going towards T3 and not reverse T3. So your RT3 will go down, your T3 will go up, your T3 sulfate will become less. So this whole activity will be there, and therefore you will have a scenario wherein again these activities will become good, and that's why you've got the big TRH surge, TSH surge, and everything goes on. Remember, preterms are born early, so they will have a different mechanism. So what you expect here is that they will have persistent activity of DIO3. So they will have lower level of T3 in that regards. They will also have low T4 and a low TSH. So they will basically behave something like a central hypothyroidism like picture. So as we always say, unless there are clear-cut indications, do not do a routine thyroid profile in a sick child. This becomes relevant in that regards. Now, these are the perinatal changes, which we all know that there is a big jump which happens in TSH and which will then come down, followed by a jump of T4 as well. What's important to remember is that the rise of TSH in preterms is lower and slower as compared to the term individual. So that's why you need to do a repeat screening in a preterm child, as we discussed in the second case. Otherwise, you will miss the congenital hypothyroidism.